All right, thank you so much for joining us today, and thank you, Dr. Saperstein, for being here. We're going to get started very shortly. We're just letting people get into the webinar. Thank you all for joining, taking your time out of your day. We're getting started very, very shortly. I just wanted to let people get in. I think we're going to have a pretty big crowd today, and we'll be getting started. So welcome everybody to our April Speaker Series webinar. Our conversation today will be all about treatment of GBS and CIDP. As a reminder, these webinars are meant to be educational and not meant to troubleshoot or consult on individual cases. As always, talk to your doctor about your individual care. If you do have a question, please type it into the Q&A box below. But again, remember that we won't be troubleshooting specific circumstances, and we are expecting a lot of people, maybe a lot of questions, and we might not get to all of them. We will try to get you a response, but if your question doesn't get answered and you're still feeling eager for an answer, feel free to email us at the foundation at advocacy@gbs-cidp.org. A very special thank you to our sponsors, CSL, Argenx, and Grifols, CSL Behring, Grifols, and Argenx. With that, Dr. Saperstein, I think we are ready to get started. So let's bring us here and get our conversation going. Dr. Saperstein, do you want to give just a quick introduction to yourself, who you are and what you do?
Sure. I'm David Saperstein. I'm a neurologist in Phoenix, Arizona. I'm the director of the Center for Complex Neurology, EDS, and POTS. I specialize in neuromuscular and autonomic disorders. I've been working with GBS and CIDP for over 25 years and have been a long-term member of the Medical Advisory Board for GBS-CIDP Foundation International. And I enjoy speaking to patients and about these diseases, and hopefully you'll get some helpful information about treatment of GBS and CIDP and MMN.
Well, without further ado, let's dive right in. Let's start at the top. When I say the top, I mean the beginning of our foundation name. Let's start with Guillain-Barré syndrome. How is GBS treated for patients? What are the treatment options to improve recovery for GBS?
Yeah, absolutely. So the mainstay of treatment for GBS, as you said, is to maximize recovery, speed improvement. And so the two main treatments for that are IVIG, intravenous immunoglobulin, and plasmapheresis. And a few decades ago, amazingly, a lot of research was done, large studies to really look at this. And so we know a few things. We know that IVIG is an effective treatment. We know that plasmapheresis or plasma exchange is an effective treatment. And we even know that there does not seem to be a benefit of one over the other. So there have been studies where people got plasma exchange and then they got IVIG and it didn't have any additive benefit. And that sometimes comes up clinically. And I think that we'll talk about that later. But the good news is that either of those treatments are effective, equally effective. IVIG is more easily available. Pretty much every hospital has it administered through an IV. Plasmapheresis requires specialized equipment. Not every hospital has it available. Requires special catheters to get it in. So again, the good news is, unless there's some sort of specifics of a person's medical condition where IVIG may not be the best treatment for them, usually IVIG is what we do. And if that can be given as soon as possible when a GBS has been diagnosed and there are significant issues, then that definitely can and does speed the recovery and hopefully improves the ultimate level of recovery. Unfortunately, and we'll talk about, hey, what other treatments might be coming down the line. The good news is most people with GBS do very well. It can take some time, but unfortunately, a significant percentage will be left with limitations or deficits. And so research is certainly going on ways to help improve that after the fact, but those in the field think that sort of getting our shot in early, are there things we can do at the outset in addition to IVIG, or maybe instead of IVIG, that can lead to better outcomes for more people?
So I love this because I think we get the question a lot about what can I do to improve my recovery, meaning what can I do to manage or improve some of the residual symptoms after GBS. So I'm very eager to hear more about some of the things for that. A follow-up question that just came to mind, is there ever a circumstance where GBS is not treated in IVIG, with IVIG or with anything, whether that's in the US or internationally as well?
Yes. So, I mean, if you look at guidelines for treating GBS, they talk about treating it within 4 weeks. The thought is after 4 weeks, you've missed your window and it's not, the treatments aren't going to be beneficial. And you'll also see talks about the severity of it. So, we usually think of GBS as landing people in the hospital, and that certainly happens most time. There can be very mild forms of GBS, and guidelines and especially payers or insurances will often advocate, if the person's still able to walk or walk pretty well, that we withhold IVIG. From a clinician standpoint, when we identify somebody with GBS, I think we're inclined to treat. Again, I'm not familiar with Europe, but I would wonder they probably have a more frugal or maybe a more practical, maybe, I don't know, or more sensible, or try to conserve resources, and they might. And then you mentioned other countries. Sadly, still there are countries that don't have access to IVIG or plasmapheresis. So there are a lot of interesting studies have been going on recently in Bangladesh and other countries to look at ways of getting treatments to them that aren't plasmapheresis or IVIG, that are accessible.
Yeah, yeah, thank you. Let's go back to the actual treatment of GBS. So if somebody has GBS and doesn't respond to that first round of treatment, that first round of IVIG or that first round of plasma exchange, what happens then?
Yeah, so that's a great question because it requires a definition of what do we mean for somebody to respond. And so the fact is that most patients who have GBS, when you give them IVIG, you don't see any immediate effect. Again, based on all that wealth of research studies that we have, we can take it on faith that, most patients are going to benefit from IVIG. There's the rare patient who within a week or two starts showing improvement, but that's the exception rather than the rule. So it gets hard because you can have a person on a ventilator or who at least is very paralyzed, very weakened, and the temptation is to say the IVIG or the plasmapheresis, whichever treatment you gave, didn't work. And that's where I alluded to. There's this desire, and often happens among neurologists less well versed in GBS, that they'll give a second course of treatment. So that also has been studied. And because I mentioned we do need to try to help patients who can wind up with significant limitations. So there's been controlled and multi-center trials to look at second doses of IVIG, and unfortunately, those didn't show any additional benefit. Using steroids, IV or oral prednisone or methylprednisolone or so-called corticosteroids haven't shown to be effective. And so, as hard as it is, the current guideline recommendations is to not give additional doses in most situations. There's been some great studies done by our Dutch colleagues who have looked at early parameters. So based on how you're looking with your GBS when you first present or within the first few weeks, they can very accurately predict where somebody's going to be in 4 weeks, where somebody's going to be in several months. So we have that data who can, where we can, and we have other information to sort of prognosticate who's going to likely do reasonably well and who seemingly is going to have a poor prognosis. But right now, it's very hard, and we just sort of hold and wait. And I get calls like that a lot as part of the medical advisory board. We speak to physicians or families throughout the country, and a common scenario is it's been 3 months since my loved one had GBS. They got treated with, IVIG, and now the doctors won't, we want them to give more treatment and they don't. And then we explain why that's the case.
Yeah. Dr. Saperstein, first I want to thank you for your physician-to-physician consult volunteer time that you do. That is such a valuable service, and a reminder to everybody on the webinar that that is something that the foundation offers. Just ask your doctor to reach out to us to speak to one of our Global Medical Advisory Board, like Dr. Saperstein, about the current treatment. And then second, we got a question from the audience. I was hoping you could clarify quickly. So we know that there's some GBS variants, and Miller-Fisher is the one that comes up. Do the treatments that we're talking about for GBS, do those apply to those variants such as Miller-Fisher?
That's a great question. So I personally say yes, and I treat Miller-Fisher the same way. Interestingly, I mean, Miller-Fisher is much less common than GBS. It's a condition where predominantly people have involvement of eye movement or eye muscles. Their balance can be affected. All of those things can happen with GBS, but with Miller-Fisher syndrome, you don't have weakness, and it's just these other features. It's much less common, and it hasn't been as well studied, but the studies that have been done have not shown a benefit from IVIG. So some people say, well, it doesn't respond to the treatment, but the studies are a lot smaller than those wealth of studies that I referred to about GBS. So I do, and a lot of colleagues, but maybe not, no, it's not universal. I tend to treat it the same way. Again, as I alluded to, we right now our best crack at GBS, or presumably the variants, is our treatment, early as we can. And so we don't want to miss that window. And I generally treat Miller-Fisher, or generally I do treat it exactly the same way as GBS. And then there's other variants where it's the motor variants like AMON or AMSAN, and those fall under the groups of people who not always, but more often than not, are going to have or do have a worse prognosis or do less well. And again, right now we treat those the same way. In the future, hopefully we'll be treating it different, i.e. we'll have new strategies so that we can definitely try to treat people where we can anticipate them having more complications or doing less well, and we'll hopefully treat them early and impact that disease in a way that we're not able to with current therapies.
Got it. Thank you so much. And you mentioned a shout out to our Dutch colleagues. For the audience, that's the International Guillain-Barré Outcome Study, IGOS. There is information on the foundation website about IGOS, as well as the current treatment guidelines. They live on our website. If you stick with us, I am going to do a quick demonstration later on our website about where to find them so that patients can find that as well. All right, moving on, a couple more questions about treating GBS. So let's think about GBS residuals, or let's think about somebody who recovered from GBS pretty well. Maybe it's been a while since they've had GBS, but they're starting to feel what they think might be GBS symptoms again. Do those typically get treated, or how are those managed?
Yes. So two separate issues. One is the concern that GBS is coming back. And so, when people are in the throes of GBS, we usually, reassure them and their family. The good news is this is bad, and we're getting you through this, but it's very unlikely for it to recur. Not impossible, and roughly around 3% of people can have what we call relapsing GBS, where they have the same thing. They have this abrupt onset, it progresses over a few weeks, it takes months to get better, and then years or sometimes many years down the road, it can happen again. Again, that's very rare, and the vast majority of that won't happen. I see a lot of patients referred to me or self-referred, concerned that now their GBS is like turning into CIDP. So it's progressing and it's becoming a chronic issue. Part of the confusion is the difference of how those of us who see GBS and CIDP, how we define acute and chronic versus what common sense would say. So as I said, a large percentage of people with GBS have chronic symptoms. So you have ongoing numbness, even weakness, pain, tingling, or so forth. And it can vary. So a person will say, well, I had GBS 2 years ago, and I still have these symptoms, so I have a chronic form. When we talk about chronic in the sense of CIDP, chronic inflammatory demyelinating polyneuropathy, we mean that the disease progresses. So if initial symptoms progress beyond 8 weeks, then by definition, it's CIDP and not an acute form like GBS. CIDP can be relapsing and remitting, but again, it's not that you have persistent symptoms, or even that those persistent symptoms may be worse. So sometimes if there's another illness, the pain can be flared up and symptoms can transiently or temporarily be increased. I mean, it's an understandable concern, but in, like I said, 25 years seeing thousands of patients, I've personally not seen a person who had GBS years ago and then transformed into CIDP. And so obviously, every case needs careful assessment and so forth. In terms of these symptoms that I've been talking about, so persistent pain, weakness, fatigue, those can be big problems, and fatigue especially can be a big issue because it's more invisible. So a lot of times, a patient is in the hospital, they go through rehab, their family, their employers, their friends are all with them and understand. And then, that person they're still having fatigue. And then they're like, oh, yeah, well, yeah, that was 2 years ago, Bob. Why? You're walking okay now, you're better. But, these symptoms can persist and cause limitations. We don't have great options for treating fatigue. Starting gradual exercise and carefully building it up may help. Treatment for pain may not be perfect, but fortunately we have options in terms of what we call neuropathic pain, pain that happens because nerves have been damaged. So there are medications, for example, like gabapentin, like Lyrica, like duloxetine or Cymbalta, or others that can potentially help quiet down that pain. There are other things that could be done as well. So working with neurologist familiar with nerve problems, or even a pain doctor, can be valuable for those people who have pain. If there's ongoing weakness, working with a neurologist or a rehab physician or knowledgeable PT, or all of those, PT and OT, can help figure out whether bracing or other ways to help make life easier, or whether somebody needs a walker or crutches or issues like that. If you've got weakness and our bodies are good at compensating. So now we're walking, but we're walking differently than we did before the GBS. That can start putting strain on joints and start causing new problems. So again, getting physical medicine, rehab doctors, orthopedists, or others involved to help deal with that can and is important.
Mhm. And if I'm hearing correctly, working with those OTs and those other specialists, that can be years and years after GBS as well.
Correct.
It's not necessarily within those few months after or during recovery. It's long term.
Exactly. So people could do well, and like I say, you compensate, but then over the years, that compensation, so it can take its toll and cause new problems with ligaments or tendons or joints or inflammation, tendonitis, and then again, yeah. So you need to see those people long term. Again, most people with GBS, do well, but exactly, sometimes we need to remember, oh, yeah, we those team members that were super valuable when you were acutely recovering, or immediately after the disease, they they have value later down the road, and we need to call them back into play.
Yeah. Along with seeing those specialists long term, are there any medications that GBS patients I'm sorry, that GBS patients take long term? So you mentioned pain management. Is that a medication that you see often for GBS patients in the long term?
Yeah, it can be. Probably of medicines that people with GBS would remain on, something to help with pain. Again, unfortunately, it doesn't fix the pain or eliminate it, but it can quiet it down and suppress it. In terms of other medicines, like to do something to their immune system to support it or modulate it, again, for GBS, there's currently not any role for that. So really, the main medicine people might be on, if any, long term, would be for treating nerve pain.
Yeah. And then just reiterating that outside of the medicines and pharmaceutical treatments, you talked about just kind of healthy lifestyle for GBS, staying in touch with those specialists who might have helped acutely for long term, such as the PT, home exercises, anything else long term for GBS patients?
No, those things, I guess, just to mention, as is often, the case, is that people more knowledgeable about GBS, may need to be sought out. So, if it has been 5 years, 10 years, 20 years, 30, it's been a long time since the GBS, a lot of doctors or even, and other physical therapists or other providers may think, well, yeah, that's over with. You're past that. And as we've just been talking about, there can be problems. And so, there can be value to being seen at a GBS center of excellence so that the providers there or the therapists that they work with would be like, yeah, this is a common issue that we see. Or it could be helpful to say, conversely, oh, everyone's blaming your GBS from 10 years ago on this. It's like, this is different. You need to see, you need a knee replacement, or, you've got a problem that's unrelated to it. And, everyone's distracted by the GBS. So it can work both ways to figure out what is or isn't going on and what's the best way to manage it.
That's great. Super helpful perspective. I feel like we're ready to move on from the GBS. I want to go into CIDP. Before we do that, I want to show a couple of things on the foundation website. So I'm going to share my screen very quickly as soon as I find the right screen to share. And just give everybody, so this is the foundation homepage. Hopefully everybody is familiar with it. And we talked about the guidelines as well. So to find the guidelines, understanding our conditions, and then we have our GBS and CIDP guidelines for treatment and diagnosis. So the GBS ones are below, sorry about that. The GBS ones are beneath, and then the CIDP, we're gonna talk about CIDP in a second, but I just wanted to show these first. There's another useful spot on our website. So under support and resources, this heading here, treatment education. So this brings us to what we call our treatments and access portal. So this is grouped by who makes your medicine. And these are only right now listing the on-label medicines for conditions in our community. But please make sure you visit this often, because as we've mentioned, there's a lot of things happening. There's a lot of things that might very soon become on label. And if you don't know who makes your medicine, feel free to just start clicking until you find the name of your medicine. And if you don't, it's possible that it's because it's off label. And with that, why don't we jump right into what is the difference between an on-label medicine and an off-label medicine? And, what does that mean in terms of GBS and CIDP treatment?
Yeah. So on label means that the medicine has been approved by the FDA to treat the specific condition. So in this case, let's say CIDP. In order for a medicine to be prescribed at all in the US, it has to be on label for something. So for example, like up until before the early 1990s, there were no medicines on label for the treatment of CIDP. We used IVIG, but IVIG was on label, or its indication, that's a synonym, its FDA approval was for immune deficiency conditions, and we were using it off label, and lots of medicines are used off label in medicine every day, and it's not a big deal, and it's accepted. But then, in the 1990s, we had the so-called ICE trial that showed that Gamunex brand of IVIG clearly was effective against CIDP and versus compared to placebo, and it got FDA approved. And then, as Chelsea pointed out, there have been other IVIG or SCIG products that have gone through the process of performing some sort of research study that met the requirements for the FDA to grant it a labeled indication for CIDP. Right now there's no labeled product for GBS, so all IVIG treatment for GBS is off label, and then again there's a handful of brands of IVIG that are on label. So the good news, once upon a time, we didn't have any labels, so we treated CIDP with different brands, and none of us felt that one seemed to work better or less well than another overall. Then, we had one that was on label, and then now we have a few, and it's complicated in terms of why is one brand used versus another. A lot of it is driven by like if you get where you get your infusions. If you get them at a hospital, the hospitals will usually only have a couple of brands on their formulary, and they decide that based on practicality and cost, and they negotiate deals with the manufacturers. And so if they use just these two brands, they get good prices for those. You could go down the street to another hospital and it could be entirely two different or two, three different brands of IVIG that they have on their formulary. If you get your IVIG through a so-called specialty pharmacy where they come and infuse it at your home, those two will have formularies. But then the insurance companies, they'll negotiate different rates and they'll say this brand is our preferred brand, or these three brands, and then unless you've had some reason why you can't take these or you've tried them and you have problems, we're not going to approve the others. Again, most docs who treat CIDP don't think there's a difference in brands. We do encounter some individual patients where, again, as I described the process, you wouldn't be surprised, and many of you have experienced it, that you got started on one brand and then your insurance changed, or your insurance changed its contracts and they say, okay, now you need to get this. And then you notice it works less well. And so we do, if somebody was doing well on one brand, we do try switching it. Sometimes if somebody's having side effects, sometimes switching to a different brand, although usually the side effects are more something that's going to happen with every brand. I mean, IVIG brand, I mean, it's all immunoglobulin. They get blood from thousands of healthy donors. They do things to make sure it's safe and there's no infections that get transmitted. But then they got to do something to stabilize the immunoglobulins. Otherwise, they're all going to stick to each other, because that's what antibodies or immunoglobulins do. So each brand has a different way of doing it. Their sort of special sauce, their special secret recipe of how they stabilize it. And again, there are theoretical reasons why some of these stabilizers and other processes may be better than others. But again, we don't know. We don't really have large head-to-head comparisons.
Well, that really answered my next question, which was why do we have different brands of IG and what does that mean? So thank you. I liked the description of, we need something to get those IG molecules to stick together. So that's the secret sauce of each company. And the side effect profile seems to be very individualized. So that sounds like it's a very personal conversation between the patient and their doctor. And the foundation has always advocated that decision should be made by the patient and the doctor, and not a insurance company or things like that. So we remain very active in helping that to advance. So not even just thinking about the different brands, but now we have IV-IG options, and now we have 2 sub-Q IG options. So can you first of all explain subcutaneous a little bit more, and then talk about why somebody might want to go from IV to sub-Q and what that process looks like?
Sure. So yeah, I mean, our in administering the immunoglobulin, traditionally it had been through an IV infusion, and quite a number of years ago, people started working out ways that, well, we can give this subcutaneously. So we inject it under the skin, into the fat. So in the stomach, in the thighs, the backs of the arms, depending on how much or little fat each person has. Some sites are more amenable to others, but almost everyone has areas where it can be injected. And why do it that way? So you don't need an IV. It's something that people generally do on their own after training from nurses. They could do it on their own, so you don't need to be dependent on a nurse. And it happens more slowly. So instead of getting like a big dose once every 3, 4 or so weeks, like we do with IVIG, subcutaneous immunoglobulin is typically dosed once a week. So you take that amount that you would be getting of IVIG over however many weeks, you divide it, and then you give generally a similar amount, a third of that if you're getting it every 3 weeks. And then instead of getting big spikes of immunoglobulin levels, which can contribute to side effects, you get more, smaller bumps, and before the levels have a chance to decline too much, you're getting your next dose the next week and then the next week. So two problems that we can run into with IVIG in terms of tolerability is, one, side effects that result from getting this big whoosh, this big load of protein and fluid slammed into the blood system, into the vascular system over a few hours. And then after about 3 weeks or so, it can be slightly different in different folks. Then the levels drop down, and then patients may notice, oh, my symptoms are coming back. And then they get their next dose of IVIG, and whoosh, they get a big infusion. And we used to think we needed that big kick and that decline, but now we find that with the sub-Q, we keep a much more steady level. So for people who have certain side effects like headaches and chills and aching and so forth, they can do better with sub-Q. Certainly, people who have trouble with IV access, getting an IV and getting the IVIG, and then of course sub-Q circumvents that. Again, people who want to have more control, people who are sensitive, like they get IVIG and it's not wearing off close to 3 weeks, it's wearing off after a couple of weeks, or it seems to be wearing off even shorter, and it's just not practical to get IVIG that often, or maybe they don't want to, and then they can get the sub-Q, they get the weekly doses. Or it doesn't have to be stored. It can be stored at room temperature, the subcutaneous preparation. So people who travel often like it. They can take it with them, and then they just do it. It only takes a couple of hours, usually once a week, depending on the dose, as opposed to trying to figure out, okay, I'm going to be in this state in June, and I need a place to get my IVIG, but then I'm going another place in August, and then it can be very difficult to try to figure that out. Whereas you can do the sub-Q. So there's lots of different reasons. As you said, Chelsea, most typically we're switching people from IVIG. We know that the IVIG works, and then we can transition them usually pretty smoothly over to sub-Q. It's something that's worth this, a lot, since it's a more recent treatment for CIDP. Many doctors and patients think like, okay, well, this is what we do when IVIG doesn't work out for many of the reasons that I laid out. But it's certainly an option, again, for somebody who doesn't want to have to get an infusion for hours, every few weeks, and they want to do it on their own time. They're just sitting watching TV or working at their desk, and they can do an hour infusion if they want to travel. So I think it's something that's worth, discussing. I discuss the options with my patients and let them choose. A lot of people don't love the idea of injecting stuff under their skin, and it does take a little bit getting used to, and there can be like little sloshy fluid pockets that take a while to absorb. It sounds bad, but again, it's usually something that most people don't think twice about after they acclimate to it. So there's sub-Q IG, and then like IVIG, there are different brands. There's one brand of sub-Q IG that's labeled for CIDP, but there are other brands that are similar that can be used off-label. So something I didn't talk about with IVIG is concentration. So there are different brands, and then within brands, some may be at a 5% concentration, and some will be more concentrated at 10%. Usually we use the 10% IVIG, and then because it's less fluid, it's less volume. If we want to make sure the person's well hydrated, which we generally do, we've come to realize in recent years that hydration with saline or with IV fluids can be a big way to help minimize the infusion side effects of IVIG. So you could do 5%, but then you're stuck with, half as concentrated a solution. You can use 10%, but you can give people IV fluids, but using 5% is an option. For sub-Q, you can administer some of the same IVIG brands. You can give them subcutaneously. So you can give the 10%. 10% is the most concentrated IVIG. And you can give it sub-Q, but the brands that have been specifically labeled for CIDP are 20%. So they're that's too concentrated to give IV, but they're fine to give subcutaneously. And obviously, if you were doing 10%, it's going to take you twice as much volume. It's going to take you twice as long. So we typically use a 20%. There's a weird 17 and a half or something percent sub-Q. So there's sub-Qs come in different concentrations. And so there are choices both on and off label for that. Most recently, I think the most recent medicine to be FDA approved or labeled for CIDP is something called HyQvia, which is referred to as facilitated sub-Q. So it's an interesting concept. So it's a brand of IVIG that can be administered subcutaneously. And it initially you get an injection called something called hyaluronic acid. And hyaluronidase, which is an enzyme that breaks down hyaluronic acid. Hyaluronic acid helps kind of keep our skin cells together, keeps fluid out. And if you temporarily disrupt hyaluronic acid using hyaluronidase, ACE is our little term that for enzymes. When you hear ACE at the end of a word, it means it's an enzyme that sort of neutralizes or temporarily disrupts the functioning of another protein. And so it basically makes a pocket, it makes more space for fluid to go into. And so you inject that usually in the abdomen, and then you create that pocket, and then you can infuse immunoglobulin, not intravenously, but subcutaneously through that pocket. But you can give it at rates that approximate what you do. They're much faster than sub-Q and approximate what you do with IVIG. So in the studies that looked at this in CIDP or study, generally around a couple of hours, 2 or 3 hours. So you can much shorter, or certainly shorter than your typical IVIG treatment, longer than your typical sub-Q treatment, but instead of having to give it weekly like regular sub-Q, it can be given every 3 or 4 weeks. And so that's definitely an option for some people to get shorter infusions. Again, certainly well suited for folks who get a lot of reactions from or side effects from IVIG, like particularly headaches and some of the other infusion rate related reactions. And so again, it goes in quickly, the facilitated sub-Q goes into the subcutaneous tissue over a few hours, but then it takes hours or the next day or so to slowly get absorbed into the system. So that's why the side effects are much less. So it's an option. Again, it's one that's recently become approved, and although the medicine's been around for years, and some of us has used it. So it's great, as we'll talk about later, what to do if IVIG doesn't work. Step one is figure out ways to get IVIG or sub-Q to work, since that's one of our most effective treatments. And then there are situations where then we need to look at other types of medicines.
Dr. Saperstein, I learned so much about sub-Q right there. Thank you so much for that comprehensive overview.
And just quickly, the facilitated sub-Q can be done with a nurse. So a nurse can come and do it. Again, it's just a few hours, once a month or every 3 weeks or so. Or a person certainly could be trained to do it on their own, similar to the sub-Q. So there's lots of flexibility.
Yeah. So just a couple takeaways from our IVIG treatment and our sub-QIG treatment. So we talked a little bit about the different concentrations, and that really has to do with hydration is what I was hearing you say. We talked about on-label versus off-label brands. We know that there's a couple on-label brands for CIDP, and then there's a few off-label options as well. And then for sub-Q, we know of 2 sub-Q brands that are working. And the newest one is HyQvia, which has that hyaluronidase that breaks down the hyaluronic acid. The way I remember this is hyaluronic acid is always in my skincare. So that's what keeps my skin nice. And the hyaluronidase breaks through that to allow the medicine to get in. that is
exactly. The hyaluronic acid makes our face skin tight, and hyaluronidase makes the skin looser temporarily, and it's completely reversible. But yeah, making more room so you don't, it's much easier to get that sub-Q.
Right. So for less frequent infusions, and your body absorbs that over time. And then there is another just typical sub-Q schedule you were saying about weekly, depending on the patient. And then I
Yeah,
wanted to just reiterate again that that transition from IV to sub-Q, that kind of takes a little bit of practice. So again, reiterating that we have this doctor-to-doctor consultation program. So if your doctor is maybe struggling to know what to do to make that switch from IV to sub-Q for you, they can absolutely reach out, and maybe one of our GMAB members, our Global Medical Advisory Board members, can help navigate that switch and some of the best practices in helping patients get successfully switched. Okay, so I want to warn you, we're getting a lot of questions about efgartigimod, but I'm not ready to go there yet. We're going to save those. So please, everyone, wait patiently. We are going to talk about some of the things that are upcoming, but let's focus about alternatives to IG therapy right now. So not necessarily clinical trials, but if IG, whether IV or sub-Q, isn't reducing CIDP symptoms, what are somebody's options otherwise?
exactly. So as I already alluded to, sometimes it's not that IVIG or sub-Q isn't working, it's that they're not tolerated. If it's truly not working, i.e., you're tolerating it fine and there's not improvement, or there's not improvement to the degree that we would hope, then what to do? So we talked a lot about how we dose, how often we give IVIG and so forth. We didn't talk about the dose, which hasn't until recently hadn't been that well studied, and still isn't studied as well as we'd like. So, when we started using IVIG for GBS, when we started using it for CIDP decades ago, we would give a so-called loading dose of 2 grams per kilogram. So we figure out how much you weigh in kilograms, which is pounds divided by 2.2. And then, if you weigh 70 kilograms, then we give you 140
treatment right
grams.
away, or is it 4 years later?
Sorry about that.
And then that would be given traditionally, again, that induction or loading dose would be given over, divided up and given over 5 days. We found that can be given more quickly. In the ICE trial, again, they gave that over 2 days in most people, and most people tolerated it well. If somebody is older, or there are reasons why we shouldn't give them so much fluid at once, that can be spread out. And then we would give this induction or loading dose, and then we would give a maintenance dose, which generally would be half of it, or a smaller amount. Again, when I started doing this, almost 30 years ago, we would do 0.5 grams per kilogram per month was a maintenance dose. Then in the ICE trial, they used 1 gram per kilogram as the maintenance dose. You get 2 grams per kilogram, and then in 3 weeks, you get 1 gram per kilogram, and then every 3 weeks, the dose generally would be 1 gram per kilogram. So they did 2 things that was different from general practice, which was they did it every 3 weeks instead of every 4, which does seem to work better based on the rate at which IVIG sort of gets eliminated or breaks down from our system. And they did a higher dose. And the $1 million question is, well, why 1 gram per kilogram? So is 2 grams per kilogram as the maintenance dose better? And we don't know that, but a couple of years ago, there was a so-called PRO-CID trial, PRO-CID, which looked at people who were who had CIDP, stable on IVIG, were withdrawn from their treatment, and then they got placed on 0.5 grams per kilogram maintenance. They got placed on 1.1 gram per kilogram maintenance, or 2 gram per kilogram. So 3 different arms, if you will, 3 different groups that were studied. And the higher doses were certainly better. There was some indication that some patients did better on 2 grams per kilogram. But again, it wasn't necessarily significant, but it did raise the intriguing idea. And physicians, some had been doing this. A lot of us, we get sort of locked into habit. And again, it's not science why we give 1 gram per kilogram. So in some patients who aren't benefiting now in light of the PRO-CID study, I will, assuming they're tolerating it well, will increase their dose from 1 gram per kilogram higher, or up to 2 grams per kilogram. And sometimes that's sufficient, so you don't even need to leave the treatment. We have basically 3 types of treatments that we know work for CIDP, and no meaning that we've got placebo-controlled, randomized studies, the highest level of evidence, other treatments that may work. So that's immunoglobulin, be it IVIG or sub-Q, corticosteroids, so prednisone, taking a pill, or getting something IV, something called usually methylprednisolone or solumedrol. And when we view prednisone, we used way before IVIG. We know it works. We used to give big doses and we give it every day, and it can have a lot of side effects. People get puffy faces, gain weight, can be irritable, can get diabetes, can get high blood pressure, or, ulcers, cataracts, osteoporosis. Not everyone, but those can be issues with it. Then we found that number one, the doses don't necessarily need to be that high if we give it daily, but if we don't give it daily, we can minimize side effects if we give it in what's called a pulse fashion. So giving a big dose either once a month or a smaller dose once a week or at some interval could have the same benefits as daily dosing, but with some of the less side effects. And so pulse dosing is how we do it now. Again, in Europe, again, maybe they're more frugal. They make more use of steroids. Steroids is certainly a great option. There's a huge disparity in cost. Immunoglobulin therapy is expensive. Corticosteroids are rather inexpensive. But the punchline is they can be effective. Again, there's individual reasons why one patient may do better with one than another, may tolerate one better than another. Sometimes it's not either or, and we use both. And so a combination of IVIG and corticosteroids. I said there were 3 treatments. The other treatment that's been well studied for CIDP that we know works is plasmapheresis. So it works. Its biggest problem is logistics. So you have to go somewhere that does plasmapheresis as an outpatient. Again, some communities have many options. Other communities, you may have no options, or it may be hard to get. And then you need some sort of special chronic catheter that's in a large vein, usually in a vein under the collarbone, what we call the subclavian vein. And those can get infected, those can get clotted, those can have problems. They need to be cared for in a certain way. Like IVIG or sub-QIG that help, but then wear off and you have to keep giving treatments. By and large, plasmapheresis is absolutely like that, and benefits usually last 3, 4, or a few weeks, and people will need regular treatments. And so plasmapheresis is certainly an option, but it's used in limited settings. Again, so when those don't work, which in recent years, we've come to realize, well, we should really try to maximize the use of the treatments that we have the best evidence for, and the most recent guidelines for managing CIDP encourage that. Then we go to treatments which we think work, but we don't have data that proves it. We don't have the high-level studies. And so in the past, we'd use a lot of what we call immune suppressant medications. So something called azathioprine or brand name Imuran, something called mycophenolate or brand name Cellcept, or sometimes even others like methotrexate. And these are pills that you would take. They don't have an immediate effect and can take months, sometimes several months, to clearly kick in or have an effect. Oftentimes they're used in conjunction with other therapies, or we may use them to help, if steroids are working, but we want to get people on a low dose or off of steroids to minimize side effects, then we would use that. And so there's different ones, and there's, our data for those are what we call retrospective, meaning somebody would look at, hey, at our center over the last few years, we've treated a lot of CIDP patients. When we look back at patients that we've given any one of these immune suppressant medicines, how many seem to respond? Again, it's not as rigorous as a forward-looking study, and then there's no randomization. So about 20, 30% benefit. Again, whether that's true or just noise that comes out of the fact that the study methodology is far from ideal. Another treatment that's often thought of as next line, beyond immunoglobulins, steroids, pheresis, is something called rituximab, or brand name Rituxan, or now there's so-called bioequivalents, which are essentially generic versions, if you will, of rituximab. Rituximab targets cells that are going to become so-called plasma cells. And plasma cells are a type of white blood cell that make antibodies. And so if you take these plasma cells out of commission, then you prevent it from making certain antibodies that may be targeting myelin and playing a role in CIDP. There have been studies of rituximab, but again, they've been small and not randomized, placebo, matched groups and so forth. And some of my colleagues are very, fond of rituximab and use that as the next line treatment. Others, like myself, we certainly use it, but we don't. We acknowledge that we don't really have great evidence of it. There are studies ongoing. There are certain subtypes of CIDP, patients who definitely do have antibodies or certain types of antibodies for whom rituximab may be a very good treatment or even preferred treatment. But that's where it gets more, when immunoglobulin, steroids, pheresis don't work, then it gets more art than science, or there's a lot of art with the science. And that's where it can be very valuable to see a specialist in CIDP and seeking out a center of excellence or another institution or facility where there are, neurologists who specialize in CIDP to figure out the best next steps. Or again, if you're somebody who's not responding to the treatments that are our best treatments, it's always a good question to ask, hey, do you really have CIDP? And so is the answer to, and not, none of these treatments are going to help you. Is there another cause for the neuropathy for which there's a better suited treatment? Or at very least, let's stop, attacking you with different medicines against your immune system if it's not CIDP and it's not going to respond to these treatments.
Yeah, yeah. Dr. Saperstein, thank you so much, because there are so many things that happen outside of just the IG treatment that I think it's important to take time to understand kind of what those other things are and why they're given. So I have a little bit of a time check for us. We have 8 minutes left, unless you can give us maybe 2 or 3 extra. There are 3 big things that I really still want to cover within the time we have left. So let me tell you what they are, and then we'll try to get through them. I would love a quick overview of MMN treatment, a quick overview of treatment for anti-MAG, and then we got a ton of questions about efgartigimod and what's kind of in the line, specifically for CIDP, what's in the pipeline. We know a lot of innovation is happening there. So I would love just a quick blurb on efgartigimod.
Sure.
So if you don't mind,
Sure.
let's start with the MMN.
Yeah, so MMN is easy in the sense that for whatever reason, IVIG right now is the only treatment that seems to work in contrast to CIDP. So corticosteroids don't work, and there are some reports and situations where it may actually worsen patients. Same with plasmapheresis. In the past, we'd use immune suppressing medicines like more potent chemotherapy agents, like something called cyclophosphamide, something that's very strongly against the immune system. And those may be options. Again, for MMN, it's all the more important to try to figure out how to get somebody to tolerate IVIG or sub-Q. Sometimes, again, higher doses may be needed. So we definitely need more treatment options for MMN. For anti-MAG neuropathy, or goes by many different names, but just for brevity, people can have a so-called IgM type of antibody, what we call monoclonal protein. Your bone marrow, or for some reason, is making too much of one type of antibody, and that IgM antibody gets in between basically our myelin or insulation around the nerves, is sort of rolled up tight, and these antibodies can unravel it. Sometimes those IgM antibodies will react specifically to a protein called MAG, or myelin-associated glycoprotein. Sometimes those antibodies aren't present, but the clinical features and treatments are the same. These patients can look like CIDP, but they're typically older. They're typically more often males than females. They often will have more weakness that's distal, meaning affecting the feet or the hands. They often have more balance problems or tremors, and there are certain things on their EMGs that sort of clue us in on that. And again, the blood tests will tell us if there's an IgM monoclonal protein or anti-MAG antibodies. A small percentage will respond to IVIG, but most don't. Most really don't respond to steroids. Plasmapheresis isn't an effective treatment. And unfortunately, we don't really know what works well because there's an antibody involved. Rituximab has been used, and there have been studies of that, and it may help. But again, MAG is a very tricky one, and it's one of those situations where knowing when to stop fighting can be important. I mean, we there are definitely things that we want to try, and we do try, but that's where seeing a specialist can be helpful because it's very easy. It can be a very slowly progressive disease, and maybe not treating is going to be the safer or better option since the treatments aren't all that effective. All right, now was that all the questions you asked before we get to?
I think so. We have so many more. I think we could have done 2 hours chatting about treatments, especially for all of the different conditions. But we were getting a lot of questions about efgartigimod, so let's chat about that. Before you do that, I do want to acknowledge that there's lots of innovation happening for CIDP. I think efgartigimod is getting called out because people's doctors are starting to talk about it. It's probably the furthest along in its innovation lifespan, and some of the other ones are just, a little bit far behind. The foundation website, as I gave a little tour earlier, there's a research portal, or participate in research. There you'll see some of the clinical trials with other things that are in clinical trial for CIDP, other treatment options as well. Again, efgartigimod just seems to be the farthest along and is the most talked about right now. So back to you, Dr. Saperstein, to give us the overview of it.
So I guess just real quickly, we didn't talk about like how does IVIG work or how does
Which was another
sub-Q
question we were getting a lot of. Yeah.
And I get it bookends with when we talk about efgartigimod or other treatments. So the IVIG does a lot of things. The short answer is we're not sure which specific activities play the role on CIDP, or it may be different in different patients, but many in broad strokes, the immunoglobulins can help clear out. So if your body is making antibodies that shouldn't, that are reacting to against your nerves and causing the neuropathy, then just by putting more immunoglobulin in, it can clear it out. Some of it is through the mechanism of what's called FcRn, which is how efgartigimod works, which we'll talk about in just a minute. Sometimes you may have an antibody that recognizes, so a good antibody that recognizes an antibody that could be attacking nerves, and they sort of stick to each other and cancel each other out. There's some role in IVIG of affecting something called complement, which will also come into play in some of these other newer therapies that potential new therapies that you've alluded to. So the good news is that IVIG does a lot of things. The less good news is maybe there's too much, and if we can streamline the treatment. So one of the goals of research has been, can we find a more efficient or targeted way so we don't need to give tons and tons of immunoglobulin, either IV or even sub-Q, and can we more target this? Plasmapheresis is an opposite strategy where we're taking out immunoglobulins, taking out antibodies, filtering it from the blood, replacing it with protein. But other stuff gets taken out as well, other factors to include complement and so forth. So, all right. Efgartigimod is a so-called FcRn receptor blocker. And basically, it's exploiting or taking advantage of sort of the housekeeping mechanisms, the way our body replaces immunoglobulins. So our bone marrow makes, or white blood cells make, plasma cells make immunoglobulins, and then some of them get cleared out, and then new ones get made. And so the normal process is the immunoglobulins get pulled out of the bloodstream, go into cells, and then some of them, this FcRn will escort them out of the cell, basically into the execution room, and they get broken down and neutralized. If sorry, they get escorted out. The FcRn is sort of the lifeguard. So if the FcRn, it's like musical chairs. if you partner up with the FcRn, that pulls you out the good door, which is back into the bloodstream, and you get recycled. If you block FcRn, then that forces more of the immunoglobulins into the destruction pathway. So that's what happens. So efgartigimod is an inhibitor that blocks the FcRn molecule. So then the FcRn can't chaperone the immunoglobulins to safety. And so you put, instead of a small percentage of your immunoglobulins getting eliminated, you're eliminating a bunch quickly and within a week, or certainly maximally by 2 weeks of the infusion. So it's an IV infusion, and you're clearing out the immunoglobulins. So it's kind of like plasmapheresis in that sense, but it's only getting the immunoglobulins, and it drops your immunoglobulins down, so that slightly puts you at increased risk for infection. Although in our experience with efgartigimod, we've been using it for a few years now for myasthenia gravis, we've seen at worst mild infections in small numbers of patients by and large. So right now, like for myasthenia gravis, you would get a once a week infusion that's just an hour, much short. Or there's also using hyaluronic acid giving shorter, or there are other forms that can be given subcutaneously that are just, very short, much less than an hour. Giving it weekly and then seeing how somebody does and repeating it. For CIDP, the studies have looked more at regular dosings of the efgartigimod. So Vyvgart is the brand, and you may see commercials for myasthenia gravis and so forth. So there's the company that makes efgartigimod has done a clinical study in CIDP, and they have that data, and that, we anticipate the FDA making a decision sometime in the summer. I've heard June, around there, where, again, to see if they will approve it, give it a label indication for CIDP. It's, really the only way the insurance is going to cover it for CIDP is if it has a label indication. Again, right now we use it for myasthenia gravis. It's exciting. It can be a good option. We don't know if it's better than IVIG. Certainly for somebody who has problems with IVIG, or reasons why IVIG or steroids aren't seeming to be good options, it's always good to have another option. The biggest problem with studying CIDP nowadays is that we've got treatments that work. So it's very hard to go to somebody, or not really ethical to go to somebody and say, hey, you're on IVIG, we're gonna take you off and we're gonna try medicines that we don't know if they work, or we're gonna put you on a placebo for a prolonged period. But so how do we study new drugs in the IVIG era? Invariably, what we used to do was take somebody stable, take them off of IVIG, prove that they got worse, then rescue them with IVIG or something else. Again, in the past, we were studying sub-Q IG or other things. For the efgartigimod trial and other trials that are now studying alternatives to IVIG, they've taken patients and they've done a step where they've not randomized somebody to efgartigimod or placebo, but they took them off IVIG and then put them all on efgartigimod, what we call open label, meaning, hey, everybody knows what you're getting. And then if you responded to the efgartigimod, you get randomized to then continuing on efgartigimod or getting switched to placebo, and seeing if there's a difference between how likely you were to deteriorate. So in the efgartigimod trial, it was roughly only 2/3 of patients got better. So a third didn't respond to the efgartigimod. And so then you took a subset and then you randomized them. So that has its issues. And then we're just looking at how likely people were to go without relapsing. And then, when we look at the final data, we'll say, hey, are these numbers as good or better or worse or not as good compared to IVIG? So again, it's exciting to have a new option, but we don't have, and for logistical reasons, probably will never have a head-to-head trial, or at least not any time soon. So again, if you're doing fine on IVIG, I wouldn't see any reason that we'd want to switch to a new treatment because it's new. New doesn't mean better. New may be better for some people, or may work well. So FcRn, there are several different companies that are making FcRn blockers that do it slightly differently, that might have different durability. So again, we're going to see a lot in that space. Another big area is complement. So very quickly,
Doctor, we took up
one of the many ways our very quick. One of the many ways our immune system functions is something called complement, where an infection gets sensed, and then it's sort of this cascade, and it's kind of like a transformer where it like these little pieces self-assemble themselves into a weapon, and they sort of come into this like molecule that then sort of tunnels into the cell wall of bacteria. So it's basically designed for certain types of bacteria, and it tunnels in and destroys them. But if certain antibodies can trigger complement against our cells. So again, in myasthenia gravis, those patients, most of them will have an abnormal antibody, and then that triggers complement to break down the muscle and affect that. And then if you can inhibit complement somewhere along the way before that weapon's assembled, then you can make the disease a lot better and significantly impact it. The flip side is, well, what do we need complement for? Certain infections, like the bacteria that can cause forms of meningitis, some forms of meningitis. Fortunately, there are immunizations for it. So with the complement inhibitors right now, people are required to get immunized at least 4 weeks or more before you start the treatment, and then you may need periodic immunizations. Actually, a lot of nowadays, like younger people, before they go off to college, are getting most, not all, but most of these meningitis vaccinations. But other than, so the risks are pretty low. They can be very effective. Again, for myasthenia gravis, it's been very effective. We have options that are every couple of weeks IV infusions, every 8 week, an hour infusion, and then even we have a daily little shot under the skin. Complement is a hot area for CIDP. Again, we don't know. The same sort of study designs are going on. So you take people and you put them on open label complement inhibitor, and you see what percent get better, then you randomize those patients. So the trick is what the information that a company needs for the FDA to give them a labeling indication is not necessarily the information that we as clinicians would be interested in, or you as patients would be interested in. And some of it is a loop. So if you can show, hey, this person did well on IVIG, we switched them and we stabilized them, that can be enough to get a label indication. Again, it's not generally enough to give us information about, is this better, or in which patient should we use it. And in the study, if only 2/3 or half of patients responded to the treatment, and then they got put into the study, what do we do in real life? Do we give it to everybody knowing that only a subset are going to improve? Will we get smarter? Hopefully we will. Like, all right, these are patients who are based on X, Y, or Z, we would think be more likely to respond to FcRn or more likely to respond to complement. Again, it's good, it's a good problem to have. We're going to have, as we get more drugs, we're going to have more questions. We're going to have to figure out how to use them optimally. But again, more options is never bad. It's exciting that CIDP is getting a lot of interest. GBS is too. So complement inhibitors are being looked at for GBS. Interesting things where, as I mentioned, like in Bangladesh and other countries like the Philippines, they don't have access to IVIG. So there's actually placebo-controlled trials going on. And we can see, how well this works. And then again, we will have to figure out how to fold that into our treatment paradigms in the US. But it's very exciting to have all this potential movement and new treatments, hopefully in the next, year or years.
Yeah, for all of our conditions. And Dr. Saperstein, when we started,
and MMN, so complements being looked at for MMN as well, where we definitely need more treatment options.
Absolutely. MMN was on my mind as well. Thank you. So when we started this, I said I was going to keep it right on time, and please forgive us. And thank you so much for being generous with your explanations and giving us some extra bit of your time. It sounds like most people participating today have some homework to please visit the GBS-CIDP.org website. On there, you'll find our research portal. So that's information about the clinical trials going on, the treatments and access page, and that will be updated when new things do come on label for any of the conditions kind of under our umbrella. And then also to learn more about the Centers of Excellence program, the doctor-to-doctor consult program, all of these things are going to be so important as we move into this new age of innovation. So with that, I'm happy to wrap up this webinar. This is This was recorded, so I'm very interested to see people's notes against your recording and your metaphors, especially with the transformers. I hope some people wrote down like a transformer during their note taking. And again, I just want to acknowledge and thank our sponsors for this program. We had a ton of questions. We got to those that we could. If you are still burning to have that question answered, please email us at advocacy@gbs-cidp.org. Thank you all so much for attending. Thank you again, Dr. Saperstein. We look forward to seeing you at our next speaker series very soon, all of our participants, and have a great rest of your day. Thank you. Bye, Dr. Saperstein.
Well, bye-bye. You're welcome. Take care.